My privilege to share with you the 2 decades or more of the harm reduction program that we implemented in Malaysia. As I was listening to all of you speak today, it really is that there is a lot of similarities between our two countries, not just in terms of we're both Muslim majority countries, but in terms of the HIV epidemiology, with big burden of disease coming from those who become infected through injecting drug use, and now transitioning to an MSM epidemic. So what I'd like to do is share our 2 decades of harm reduction experience in Malaysia. And you've already heard from Dr. Anita earlier that I guess Malaysia's strength in the HIV response is in the partnership between the government, NGOs, as well as academia. At the time when we implemented the harm reduction program, I was wearing the hat of the president of the Malaysian AIDS Council, which by history was actually initiated by the Ministry of Health in the mid-1990s or even earlier, in response to the HIV epidemic. Ministry of Health, I believe, was getting a lot of requests from small NGOs to fund their programs, and had the foresight to develop or to put together this council so that there was only one source of civil society body that the government deals with, so to speak, with the other NGOs coming under the umbrella of the Malaysian AIDS Foundation. So back to harm reduction, the war on drugs in Malaysia. Even till now, there is a dominance of law enforcement over health, and a moral and religious framework that's linked to prohibition. And very much in the early years of the HIV pandemic, abstinence was the main goal for people who use drugs. The trend of drug use has also changed from being predominantly heroin, and now I think, like many countries around the world, heroin is still used widely, but what we're faced more and more is with amphetamine type substances, and now even worse with synthetics like fentanyl and so forth, although that is hopefully not going to that as is being seen in the US and so forth, but it certainly is creeping. At the time when we advocated to the government that something needed to be done, we and countries like China and a few others had the rather not very pleasant label of being countries with mega epidemics of HIV, which was even published in the Lancet, with around 80% of the prevalence of HIV was amongst people who injected drugs. And so a group of us got together and kind of advocated to different stakeholders, particularly politicians, but also to members of law enforcement, etc., that something needed to be done, because we were seeing up to 6,000 new cases annually from injecting drug use. And I guess at the time the stars sort of aligned, because we were also at the midterm review of the predecessor to the SDGs, the Millennium Development Goals, and reversing HIV and TB was the only goal out of the 6 that Malaysia didn't achieve, and that kind of made the government sit up to listen and give us the go-ahead to do harm reduction, both opioid agonist therapy and the needle syringe program. So we started off with pilot sites for the needle syringe program under the umbrella of the Malaysian AIDS Foundation in Council. Three sites in Penang, KL, and Johor back in 2005. So Malaysian AIDS Council oversaw the implementation of the needle syringe program with its partner organizations, and Ministry of Health undertook the implementation of methadone maintenance treatment. In parallel, there were also general practitioners who were providing methadone to people who use heroin. As you can see there, through the years, what was a pilot project, the important thing that we did during this pilot was actually have a very strong M&E component, so that we were able to inform the government of the progress of the program, but also the outcomes. And that led to the government agreeing to expanding the both the opioid agonist treatment, or specifically methadone and NSP, to this day. And I think we're proud to say that up until recently, most of the funding is domestic funding, until we got a small by global fund standard. It was large enough in, we're grateful in Malaysia, but by global fund standard, it was relatively small that supported the needle syringe program. But as you heard from Anita earlier, we've since transitioned back to domestic funding for harm reduction, because Malaysia is actually going to even completely have to transition out of the global fund, and this is probably going to be our last chance with this next round. So the harm reduction program is now well and truly part of the national HIV response, and incorporated into the funding, as you heard earlier. And this is a success story that I'm proud to share with all of you. Like I said, in the late 1990s, early 2000, that prompted us to really do something was because we were seeing an escalation of infections, of new infections reported to the Ministry of Health as a result, or amongst people who use drugs. At the peak, we were seeing about 6,000 new cases a year. And through the years, you can see that green line has steadily decreased to now that we're sort of in the last few years averaging about 300 or so new infections from drug use, whereas the sexual transmission, as you heard earlier, is increasing. And a component of that sexual transmission is also a type of drug use, which is chemsex, but has to be approached rather differently from the traditional harm reduction needle syringe program and methadone maintenance treatment. So, like I said, the needle syringe program is delivered by partner NGOs under the auspices of the Malaysian AIDS Council throughout the country. Whereas the methadone treatment is through Ministry of Health clinics, and to some extent through also private GPs. We did have at some stage methadone in prison, but that unfortunately has faltered a lot, and I think it's something that we need to relook about the provision of methadone pre-release or in prison methadone pre-release, because 60% of people in prison are in prison for for drug use. And so, like has been said by Anita, it's not just about provision of methadone, or not just about provision of clean needles. We do try and make it comprehensive with all the other elements that's recommended by the WHO, as you can see there. The needle syringe program is largely delivered by former or current drug users and other members of the key population. So it's a peer led by and large program, And with methadone, it's in clinic, but also what you heard earlier, the SKPH model, where there's co-location of the services that's provided by NGOs at in close proximity to Ministry of Health clinics. And I think this model has worked extremely well, not just for people who use drugs, but also for other key populations. Back in 2011, so Malaysia, I'm not sure what the model is in Pakistan, but like many other Southeast Asian countries, Malaysia adopted this compulsory rehabilitation model. Compulsory rehabilitation, I say in inverted commas. It's not evidence-based, no provision of methadone. And we had this, I think at its peak, there were about 28 of these, what's called PUSPEN, compulsory rehabilitation centers in Malaysia. Around 2010, we had a very enlightened Director General of the Narcotics Department, which is under the Ministry of Home Affairs, who worked with us in health to transform these compulsory rehabilitation centers into voluntary centers that also provided methadone. And we were able to do some evaluation of these compulsory rehabilitation centers that were transformed into these cure and care centers, and the results were very, very encouraging indeed. As you can see there, more than 50% of those who came forward for these voluntary treatment centers felt that it helped them maintain employment, continued education, improve family relations, etc. Bearing in mind that when they're in these compulsory centers, they're in there for usually 2 years, if not more. However, because of the laws, the drug laws that are as such, those transformed centers were actually working sort of outside the kind of legal requirements, and when she retired and subsequent director generals came to lead the narcotics agency, they felt that this was wrong and reverted back to the compulsory centers. We were again fortunate during the time to do a comparison of the compulsory center model versus the voluntary methadone treatment that were being implemented hand in hand. And as you can see there from the Kaplan-Meier curve, it is without a doubt that those receiving voluntary treatment in the community did much, much better than those who were in the compulsory detention centers. Despite this very strong scientific evidence in the Lancet, no less, we still were not able to convince the government to go back to that voluntary treatment center model. But we've kind of got work in progress. To support the work that everyone has done on harm reduction, and to ensure that we get continued government support and funding, we also did a cost effectiveness model that was supported by the World Bank, and we were working with colleagues at the Kirby and at Yale. And as you can see here, the results showed that with harm reduction, we were able to avert a significant number of people from acquiring HIV. And as you can see there, if projected to 2050, we would have averted nearly 100,000 new HIV infections as a result of both the needle syringe program and the opioid agonist treatment. In terms of dollars and cents, we showed that it saved the government just in treatment costs for HIV alone. We didn't compute treatment costs for HCV, and we didn't factor in the cost of the revenue from them, say, going back to work, etc. This is just cost saving from direct health care for lifelong antiretroviral therapy. And we showed that we saved the government in the first 7 years of the program approximately 47 million ringgit, which translates to about $10 million. And if you, again, project that to 2050, close to R1 billion. And in terms of ROI, this definitely made a lot of sense. And so learning from all of that, given that now harm reduction is very much entrenched within the public health programs at the Ministry of Health, but we learned a lot of, we did a lot of learning, not just from the work that we're doing in prison, but through interactions with people who use drugs and feedback, etc., that really harm reduction is just in a way firefighting. What we really need to address is are the drug laws that lead to increased risk of hepatitis C and huge burden of hepatitis C, increased risk for HIV, and during the COVID period, because 60% of people are in prison for personal and non-violent drug use, 51,000 prison inmates became infected with COVID-19 as a result of prison overcrowding. So right now, a number of us are actively advocating for drug policy reform, and happy to say that we are getting support from the government, using those arguments that I've shared with you in terms of the cost savings, and also cost comparisons when it comes to incarceration versus treatment with methadone. It is not easy because they're trying to convince law enforcement and Ministry of Interior that it is time now to view drug use as a health and public health problem rather than purely a law enforcement issue. But I'm a glass half full kind of person. I feel like we're making progress in small steps. And so that's what's happening at the moment. So these are sort of the arguments we use with government policymakers on why there is a need for drug policy reform in Malaysia, from the burden of infectious diseases to overcrowding of prisons to perpetuating the poverty cycle of those affected, because really, those who get incarcerated are those, those who are at risk of drug use in the first place. Many of them are from poor families, and it perpetuates that cycle of poverty when they're incarcerated, leave families behind, and so forth and so forth. And we're really pleased to see at the global level, and as one of the other hats I wear is as a global member of the Global Commission on Drug Policy, which is advocating at the global level on a public health approach, and we are now starting to see changes towards and discussions, serious discussions around decriminalization of possession and use of drugs, with many countries, increasing number of countries adopting this, most recently being Germany, and recently at the UN CND in Vienna, there was, for the first time after 4 decades, that harm reduction has now been adopted at the CND as a language, but also as a modality for the HIV response. And that, for those of you who are in this circle, you know that was a significant advance, given that the Commission for Narcotics Drugs has always been somewhat against harm reduction. So there is a UN system common position on drug-related matters, including now embracing harm reduction and looking at drug use as a public health matter, not just a law enforcement. So like I said, baby steps in Malaysia, but Ministry of Health has recently formed a national task force on decriminalization, and the current Minister for Law, this is a former Minister for Law, is also very much supportive of looking into the many laws that we have on very punitive laws on drug use in Malaysia that has led to significant burden with HIV, Hep C, TB, and other related diseases. So with that, thank you very much for your attention.